Yes. Uh,
Good evening, everyone. Respected Dr. Ridul Agarwal, members of IADP, and dear doctors, we welcome you back to another episode of Learn from Our Master series organized by IADP. And yes, we are crossing 50 webinars is definitely an amazing ride so far. And I thank all the doctors who are attending our webinars and other platforms like our Instagram and Facebook pages, and we are very humbled to see your positive feedbacks. For those who are attending our webinars for the first time, today we will just give a brief introduction. We are the International Association for Dental Practice Excellence, a dental platform in which we believe quality education always ensure predictable outcomes of dentists of all disciplines and abilities. Our organization is established based on the fact that the dentistry is complex and requires ongoing learning experience. We conduct various webinars and workshops to enhance the skills of dental professional and guide their dental journey. So, without further ado, let us start our series episode in which our topic of discussion is Psychology of Smile Designing, given by Dr. Ridul Agarwal. To speak a few about Sir, Dr. Ridul Agarwal is a distinguished prosthodontist and implantologist with over 11 years of experience. He completed his master's from the reputed Savita University and bachelor's from Manipal University, India, following which he was awarded the prestigious membership in prosthodontics from the Royal College of Surgeons, Edinburgh, after clearing a series of examinations in 2011. Having worked with Dubai Health Authority and Mediclinic for over 10 years, he was awarded the fellowship in dental surgery from the Royal College of Surgeons, Edinburgh, the highest recognition for a dentist by the college. He has also been awarded the prestigious fellowship of International Congress of Oral Implantology and membership in prosthodontics from the Royal College of Physicians and Surgeons, Glasgow, and is now an examiner for the Royal College, a position held by very few. Okay, without wasting more time, I would like to invite Dr. Ridul Agarwal, sir, for today's discussion.
Thank you, Dr. Juna, for the lovely introduction. Thank you all for joining in. I see some people still joining in.
السلام عليكم. شوفي
Am I audible, Dr. Juna?
Yes, doctor.
Yeah, okay. In case, I'm not audible, I think automatically it got muted for some reason. But in case it goes mute, just let me know. My phone is with me. I'll put it on loud. So in case you message, I can listen to you. Without any wasting any time, we will dive into the topic today, which I'm sure will be of help to everybody who is going to be listening to it. Regarding question answers, if you have any questions, you can always ask me in the end. You can type it in the chat box. We can take them through in the end. And I'll take roughly 45 minutes to 50 minutes to finish this lecture. And hopefully we'll be done within time. Is my screen visible, Dr. Juna?
Yes, it's visible, doctor.
All right, perfect. So good evening, everybody. Thank you for joining in. Today's lecture is going to be on smile designing a bit, on how we associate a person's personality to designing the smile. And there are a few more parameters that are required to be able to, evaluate a case and do it properly. Now, when it comes to treating an aesthetic case, there are a lot of things that matter. A lot of things have been taught to us when we are in college, or when we are studying, or during our journeys, we learn few things. But there are still few things that I feel are way more important when it comes to planning a case. One, of course, is consent. I've seen a lot of people missing out on taking proper consents for smile designing cases. So it's very important for us to talk about consent, have a written consent, talk to the patient about your benefits of the treatment, talk about the alternatives and the risks associated with the treatments. You need to understand first that it is a irreversible treatment modality. So for you to be able to do veneers on any patient, you need to make sure that the person is an ideal candidate. It's not about cutting teeth, it's not about makeup that you can remove. It's a irreversible treatment procedure. Whether you are doing composites or ceramics, doesn't matter. Once you touch a tooth is touched. Which takes me to the second point, which is ethics. So always make sure that the first point in your head should be do no harm. That's the first fundamental principle of ethics, and I think everybody should follow that. I have few cases to show you. I don't have a lot of cases because I really don't do veneers on every patient that I see. I choose my patients, I understand the patient needs, and understand the next point, which is patient expectations. A lot of time you would see that patients would come with unrealistic expectations. Those patients I always believe are better untouched, or tell the patients that there might be a better alternative or a better dentist doing it. So patients expectations should be judged, should be taken into consideration before you decide a treatment. And that takes me to the final point, which is your treatment plan. So whenever you decide a case, make sure your treatment plan is decided on day one. Should not change ideally during the treatment. I know there can be few cases wherein the treatment plan would change, but in general, treatment plan should not change. I have already been introduced by Dr. Juna, so I would not be wasting time on my introduction. Just for a quick one, I'm Dr. Ritul Agarwal. I've been practicing in Dubai for over 13 years now. I am a tooth-based prosthodontist. I love working on teeth more than on implants. My main focus of work is on indirects, so I focus more on ceramics, whether it is anteriors or posteriors. I do directs, I do implants. That doesn't mean I don't do them. But what I love most is, of course, working on teeth, and that too with indirect restorations. This is where I've been working for over 13 years. My association with Royal College of Surgeons as an examiner. So I examine for the membership in prosthodontics examination, and I've been doing this for the past 6 years. So any prosthodontist listening to this lecture would want to appear for this exam, I would love to, examine you. I generally do examine in Dubai, and that's where I, take part in the exams. I'll take a quick 1 minute stop on this slide. This is where I am mostly available. So all of you can follow me here. I put a lot of educational content on my page. There is a lot of work that goes in to make this page to what it is. Hello. All right. So, you can scan this QR code. You can search my name on Instagram. Find me there. Do follow me. If you have any questions regarding this lecture, which I'm not able to answer because of time constraints, I'll be more than happy to answer. I put up all my courses here. So show some support and go ahead and do follow me on this particular page. Now let's look at, when it comes to smile designing, there is something called as personalized smile designing. Each patient will have its own characteristics, and we design the smile based on the person's persona. So, in personalized, there is a word called persona. Persona is basically how a person would like to project themselves in front of the world. Now, some people would like teeth that would enhance their one side of personality. So that comes to the most important part is when we have to talk to the patient, we need to understand the reason for the treatment, and also we need to understand what is it that the patient wants out of the treatment. Some people would want teeth that would enhance their personality as a leader. So you need to give more rectangular teeth, which of course we're going to discuss later in the lecture. But persona is something what a person would like to project themselves when they are out in the world. Every smile is different, so there is no copy paste. There is nothing like you design one smile and then you are just copy pasting it in all the patients. A little bit of imperfection, a little bit of design that suits the personality is what the ideal aim of being a good prosthodontist is. Case like this, wherein a patient comes with a problematic tooth number 9, which is your low upper left central incisor. Yes, I could have done 20 veneers for this patient, but generally what I like to do in most of my patients, as we go forward, you will see, I tend to avoid lower veneers. I mainly work on the upper teeth because those are the teeth that tend to enhance the aesthetics most. I like to not touch the teeth that are very healthy. Yes, I do some whitening, I do some restorations in the lower teeth, but the end result was super nice just by working on the upper teeth. A case like this, patient complained of eroded teeth on the upper four. I wanted to do 2 veneers for her, but the open bite on the right side made me do 4 for her. And that was how we ended up with this case, is just by some whitening and just doing 4 veneers for the patient. That's what I wanted to understand from this lecture, is that it's not always about doing more. Sometimes, sometimes no. Always, the lesser you do, the better eventually it's going to be. So plan your case properly. Planning is the key. Right from where we start, how do you design the smile? How do you execute it? And how you're going to bond it? Everything is going to change how you're going to do your dentistry. Now, why do you think that we are getting more patients for veneers or for aligners? Because, of course, we are more focused on how we look. We have a mobile phone, all of us. We look at ourselves more than what we used to do before. Sorry, I'm just checking if it is something related to. Yeah. And it just because of this availability of the content that people want to look better. And, as we go forward, you will understand more. Now, it's very important to, I know there are a lot of people on Instagram. There are a lot of people who show their before afters. I would really request everybody to kindly mute themselves. Thank you. So when you look at it, you will see that there are very few people who are going to show their preps, because I know for a fact that for veneers, a lot of people do over preparations. A lot of people would prepare teeth just more than what it is needed. Unnecessary root canals, unnecessary sensitivities, unnecessary exposures of dentines. So it's very important for you to know, or learn from somebody who is willing to show their preps to you, because it is so important for you to understand how a good veneer prep would eventually look like. Patzer was a person, he kind of went again around the world. He wrote a book on why looks matter more than you imagine. um, Dr. Juna, can I continue?
Yes, you may.
Because the recording was stopped. Do you want me to continue or stop for a while? All right.
Okay.
So it is very important that you think about things differently. Not every case you are going to do 10 or 20 veneers. Yes, I always avoid doing 6 veneers as a clinician. If I have to redesign a smile, it's always 10, because premolars are generally a part of aesthetic zone. And again, when you do only 6 veneers, the case looks not that great. I would prefer doing 1, I would prefer doing 2, I would prefer doing 4 based on the case. Or if I have to do a full case, it has to be 10 teeth. Now, when a case comes to you, there are a few things that you need to understand. First thing is always identify the problem. A lot of times these days, the problem is not dental, it is more of a mental problem. A lot of patients have got perfectly looking set of teeth and they want to go better. You need to draw a line at a point wherein you feel that your treatment could make a difference. That is one thing. Second thing is, you need to understand why the teeth are there at that stage of life in the condition they are. Is it because of poor oral hygiene? Is the poor dietary habits? Is the patient's occlusion not correct? So it's super important for a clinician to identify the problem first. The second step in the treatment would be forming a customized solution. As I told you, each patient is different and we need to find a customized solution. And finally, as a clinician, you should be knowledgeable enough with the materials, with the prep techniques, with the soft tissue management, with the bonding protocols. So much is there for a case to be delivered. It looks simple, it looks quite nice to do, but if you want to do it properly, it is a lot of hard work, it is a lot of knowledge that you need to have for you to be able to do a case properly. The objectives for today's lecture, of course, we are going to discuss smile analysis. We are also going to discuss on how we decide the tooth shape based on the personality, and I'll also touch on the importance of soft tissue when it comes to any case that is prosthodontics, more so when it comes to aesthetic enhancement. The first thing that we are going to look at is how do we decide the shape of a tooth based on the personality of a person. Now, Carl Jung, he kind of came up with the concept of archetypes, and he came with four basic archetypes. The four basic archetypes were basically symbols that are uniform throughout the world. According to him, the four basic archetypes, the number one archetype is anything that is vertical, it signifies strength. That's why, these big cities who want to show their power would want to have tall buildings. So anything that is vertical, it signifies strength. Anything which is horizontal, it signifies stability. So you go to a beach, you go to a mountain, if you find yourself peace because you see horizontal stuff. So anything that is horizontal, it is stability. Anything that is inclined, it shows dynamism. And similarly, anything that is rounded would show delicate. Now, these are the four basic patient personalities that we see, or a mix of all of these. But in general, either the person would be a very strong person when you talk to the person, or a person is more calm, more dynamic, or more delicate. These are the four teeth shape that we study when we are in college. One is the rectangular tooth shape, one is the square tooth shape, you have the triangular tooth shape, and you have the oval tooth shape. In nature, we have all the four teeth shape, and some people would look absolutely amazing with square teeth. Some people will look absolutely amazing with triangular teeth. But we need to understand that when we are doing a case, when we are trying to improve aesthetics, we don't do either square or triangular designs. The reason why we don't do is square teeth generally end up in a not a very aesthetic proportion, whereas a triangular tooth with very highly result in a black triangle. So as you see in the picture itself, both the pictures are right in front of you. In a triangular teeth, there is a very high chance of a black triangle. So when I do my veneer cases, I generally have either a rectangular tooth or a oval tooth or something, a mixture of both the teeth depending upon the person's personality, and then proceed with the case. Visagism is a concept that was given by Philip Hallowell. He again wrote multiple articles on how these behaviors affect your dental treatment, or how emotions, how identity, how behavior, or how psychology would affect your patient selection or designing the person's smile. So according to him, also there are four basic categories of patient: the strong, dynamic, calm, and delicate. And by now we know that if a personality is strong, a person would like to project himself as a strong personality. I would like to give them more rectangular teeth. Now, if you look at this picture, I mean, these are four characters from Game of Thrones. I mean, you can pick up any series, you can pick up any TV show, you can pick up any theater. You would see that the person playing the lead role will always have a rectangular face. The third picture where I've written calm, the actor might be the best actor in the world, Oscar winning, Emmy winning, but there is a very rare chance that that person would be given a role of a strong personality. So you need to also understand the patient's face. You need to understand the personality. And based on that, when we do our smile designing, we decide the shape of the tooth. These are four of my patients, all have different facial characteristics, all of different nationalities, all of different ethnicities. But when we talk to the patient, we decide what plan would suit the patient. And again, treatment plans differed for all the patients that are here. The first patient, I did 10 veneers. I mean, of course, there were some crowns on the upper teeth. Second patient, I did only 4 veneers. That was more than enough for me. Patient didn't want really a huge smile enhancement. Third patient, of course, she wanted to go with whiter teeth, so I had to do upper and lower 20 veneers for her. And the final patient, I did 4 crowns for the upper anteriors with some whitening and some restorations, overall giving the patient the perfect aesthetic appeal the patient needed. So a strong personality would have a rectangular tooth. A dynamic personality would have little triangular teeth. A calm personality would have little squarish teeth, as you can see. And personality with slightly oval face, I try to give slightly oval teeth. I mean, they are not very oval, but there is a stark difference between the first patient and the last patient. That was about personality and tooth shape. The point to be taken here is talk to the patient, understand the personality, understand the reason for getting the treatment done. Is the patient a CEO of a company? Does the patient want to be projected as a leader? Automatically, you need to give teeth that are more rectangular. Female patient, soft, you can give slightly oval teeth. So personality would definitely define how you are going to choose the tooth. Few other factors that we want to consider is one is the smile frame. Now here is also an important point which I see a lot of dentists doing mistakes is not taking proper records. I would really suggest everybody listening to this lecture to take proper records, and by proper records I mean the patient has to sit on a vertical chair back against a wall, not on a dental chair. You don't take extraoral photos on dental chairs. Stop doing that, please. You need to also understand that you need to make patient comfortable enough for the patient to give the spontaneous smile. If you are not able to give the patient the spontaneous smile, your case might look very good in the clinic, but 10-15 days later, the patient might come back and tell you that I don't like it because you forgot to check your work in a spontaneous smile. So planning a case in spontaneous smile is the key. That's why you need to make sure the patient is comfortable with you when you are taking pictures. Not on the first appointment, you start taking pictures. Spend some time with the patient, let the patient know you. Patient should smile from the eyes. You should be able to see a genuine smile on the patient's face even before the treatment, even though howsoever conscious the patient is. Few other factors that, I mean, there are a lot of factors that I would like to touch upon, but then again, based on the time that I have today, there are few important factors that I want to consider today is of course the central dominance. Central dominance we are going to cover up a little later when it comes to tooth proportions. Incisal projection, in most of my cases, I really don't alter the incisal projection. They generally tend to follow the lower lip. So the lower lip outline would give me my smile arc. There are horizontal projections, triangular projections, but in general, I've seen that 99% of your patients would fit in the profile when you match your incisal edge positions and the canines with the lower lip. Shape of the tooth, we have already discussed in detail on how do we decide the shape of the tooth. And finally, we have the angulations of your teeth. Midlines is something that is very important when it comes to smile designing. The main point that I want you to remember here is that make sure that the midlines are straight or at least in the correct flow of the patient's midline. Never have a canted midline in the last result that you provide the patient. If you end up with a canted midline, it's the most noticeable flaw when it comes to even a layman looking at it and understanding it. So it's better to have, not better, it is needed for you to have a straight midline at the end of the treatment. A little bit here and there doesn't really matter. I mean, in terms of the discrepancies between the midlines, upper and lower, upper and the face, 3 to 4 millimeters, it's not noticeable. But in general, you need to remember that it should be straight. The most important factor when it comes to smile designing or planning any case that involves aesthetics is your incisal length. Whether you are doing a full mouth rehabilitation, whether you are doing only 2 veneers, you need to know where your incisors are going to end. Your treatment will start with your incisor position and everything else is planned around it. So how do we decide the incisal edge position? There is a formula that you can remember. It's called the 42.2 rule or the 422 rule. 4 is the incisal display at rest for females, generally at rest. For males, it's around 2 millimeters. So for males, it's slightly lesser exposure. The first 2 is the amount of pink that you should be able to see when the person is laughing. Again, it will depend on the lip. Some people have got more pink visible, some people have got less pink visible. Can you please mute the participants, please? Thank you. And the last 2 is your distance between the vermilion border of your lower lip and the upper incisors. So if you remember this rule when you are doing your planning of the case, you should remember this. So when the person laughs, you should be able to see around 2 millimeter of pink and 2 millimeter of distance between the vermilion border of the lip and the upper incisal edges. You can also ask the patient to say F and V. When the patient says F and V, the incisal edge should be touching the vermilion border of your lower lip. So F and V are very important sounds that will help you in planning the case. And this rule is also going to help you plan the case. How I do it in my practice, I generally do something called as direct mockup. Now, this is a fairly easy technique to learn. Okay, a technique that is going to help you in terms of how you are able to convince the patient to get the treatment done. It's a great convincing tool. If you do it properly, if you learn the technique properly, you will be able to easily convince patients to get the treatment done. Now, whether they get it done because of the financial issues, that's a different story. But in general, you're going to take some composite, you're going to place it on your teeth. It will take 5 minutes for you to do it, and it would leave an impactful impact on the person you are doing it on. So generally, I do direct mockup as a technique. If I'm in person, I don't use what do you call? I really don't use digital stuff a lot, because sometimes when I use digital dentistry to convince a patient, I might overpromise the patient. Patient would remember that image, and in the end, when you are able to clinically do the treatment, you might not do the same thing what you did digitally. So my practice, not that I don't have an access to a scanner, I have used all scanners. But as of today, I believe in impressions. I do impressions for all my cases. But the fit of my restorations is so much better with a good impression than with a scan. I know people who do excellent dentistry with a scanner. I have nothing against those. Do whatever you like to do. But unless you know how to make a good impression, I don't think it is possible for you to take a good scan. Because from an impression, you will learn your mistakes, which you are eventually going to not do when you are doing your scanning. There are FAB scanners, but as of today, I do impressions. I mean, you can call me old school, but it's not that I don't know about scanners. I've used every scanner possible mostly. But in general, I feel you should know how to make a good impression. That is super important in dentistry. When it comes to proportions of teeth, now I'm talking about proportions of central to lateral, lateral to canine. A lot of proportions have been given in science and research. There are two that are actually very important. One is the golden proportion. A golden proportion is basically if my width of the central incisor is around 10 millimeters, my lateral incisor would be around 6.1 millimeters or 6 millimeters. Generally, golden proportion, when we use it in dentistry, it tends, sorry, 1 second, I'll stop the share. Just 1 minute, please. I will come back to it. Okay, give me 1 minute, all right. Yeah. Apologies for that. So golden proportion is generally not what I use in my practice. I would still prefer using red. Red is called recurrent aesthetic dental proportion. Now the difference between red and aesthetic dental, in golden proportion is not much. If my golden proportion was 60%, my recurrent aesthetic dental proportion is averaged at 70%. So if my central is around 10 millimeters wide, my lateral would be around 7 millimeters wide. Now you would be like, what would 0.9 millimeters make a difference? But you need to understand, to add that 0.9 on the lateral, I'm also reducing 0.9 from the central. So in general, when you do golden proportions, you would see that your centrals are slightly more dominant than what they should be. They look bigger than the ideal proportions. So I prefer using red in my practice, which is the recurrent aesthetic dental proportion. And in general, it's around 70% rather than the 60% of your golden proportion. When you are doing your direct mock-up or when you are deciding the shape of your central incisor, this proportion comes into picture. Generally, the length to the width ratio of the central incisor is around 80%. That's the most aesthetic. If the length of the central is 10, the width is going to be around 8 millimeters. In practice, you are never or mostly not going to get exactly 80%. Anything between 75 to 85 works perfectly well. I generally avoid 70% because that leads to more triangular teeth, and I tend to avoid the 90% because they lead to more squarish teeth. And as we discussed during the initial part of the lecture, that for reasons aesthetic and black triangle, I tend to avoid triangular and square teeth. So my mainly proportions of the teeth would average between 75 to 85%, the length to the width ratio, and 80% in most of my cases. Dominance we have already discussed. If you do golden proportion, you would see your centrals are slightly more dominant. Some patients would like that. Some patients would not like that. So I would prefer using a recurrent aesthetic dental proportion that would kind of harmonize my centrals to the laterals to the canines and in general gives a better result. The last thing when it comes to dental aesthetics is buccal corridor. Now, buccal corridor is the lateral negative space which is there around the canines and between the cheek and the canines and the premolars. I would want you to focus on this because I know there is a lot to focus when it comes to smile designing, and we sometimes tend to forget about the buccal corridor. If you want to have a value to it, if you combine the width of your central, lateral, and the visible portion of canine divided by 3, that should ideally be the width of the buccal corridor. It's more of a subjective feature. I don't want your veneers to become very broad, or I don't want the arch to be very narrow. So in general, you should be able to see buccal corridors on the side of the teeth. It's more important when you're doing complete dentures or you're doing all on 4 cases or complete arch rehabilitations without teeth. Generally, when you have teeth present and you are not doing orthodontic treatment to manage the arch width, I mean, that is something you might not be able to control much. But still, it's always better to keep that in mind. The last thing that today we are going to discuss is something that I really pay attention to is the soft tissue health. Now, these are pictures that were taken on the day of bonding. That's a left picture. The right picture is the picture that I took probably 1 month after bonding for the same patient. You need to understand that your soft tissue, there are two things, the health part and the aesthetic part. The aesthetic part is very important when it comes to treating patients having a high smile line or even an average smile line. You don't want disharmony between your centrals or laterals or centrals between canines, one central long, one short. Ideally, we want to avoid that. In a person with low smile line, a little bit discrepancy is workable. You don't really have to correct that in all patients. But in patients who have got average smile line or a high smile line, we need to pay focus on the aesthetic part. The second, or I would say the first thing that you should pay attention is health. If your soft tissue is not healthy on day 1, it is not going to become healthy after you finish the treatment in most of your cases. So the first job as a dentist is to make sure that the hard and the soft tissue and the junction between the hard and soft is healthy. So if your tissue is healthy before you do the preps, and if your provisionals are good, if your preps are good, you have done a good retraction and a good impression, the day that you have to bond your veneers, your tissue is going to be absolutely healthy. So don't work on unhealthy tissues trying to finish a case quickly. If you do gingivoplasties, you do scalings, you do deep cleanings, wait for some time. Let the tissue heal. See how your tissue is reacting to whatever work that you have done. And only then you are going to proceed to your, hard tissue work. In terms of aesthetics, the centrals and canines are generally at the same level. Laterals are slightly lower than the centrals. But again, as I told you, it depends on case to case. You don't have to really do this in all the patients. A patient having no visibility of the gingival zenith, you don't have to subject the patient to unnecessary surgeries to correct that. But in patients with high smile lines, it's always better to correct the aesthetic component of it. Another photo on the day of bonding, you see how the soft tissue is. There is no bleeding, there is no inflammation. This happens if you know how to do proper provisionals. If you don't know how to do a proper provisional, how to make a proper index, what material to use, your soft tissue is going to be inflamed when you remove your provisionals. So each step, right from preparation to doing a provisional to removing a provisional, is equally important. So the better your periodontal health, the longer your restorations are going to last. and it goes vice versa. The better your restorations are in terms of their fit, in terms of their adaptation, in terms of their cementation, in terms of emergence profile, there are so many things that would eventually make sure that your periodontal health is maintained. So summing up, what are the requirements for a case that has to be having good aesthetic outcome? Number one is attention to detail. Now, what I want you to understand is the attention to detail will start from the moment the patient walks into the clinic. I'm not talking about only the clinical details. How the patient is talking to the staff, how the patient is talking to you. Has the patient got expectations that are very difficult to meet? Does the patient have very thick fat here? You need to ask. You need to also pay attention to the patient's diet. Is the patient having GERD? A lot of patients these days suffer from erosion because of stress, because of diet habits. People are suffering a lot from reflux. And most of the patients that I see are having eroded dentition rather than attrited dentition. You need to make sure to figure out, is it attrition that is leading dentition to where it is, or it is erosion. Because if you don't, then whatever you do is eventually going to fail. The second thing that I want you to focus on is establishing an accurate diagnosis. So this diagnosis can be an overall diagnosis for a patient and then diagnosis for an individual tooth. Is it pulpitis? Is it irreversible pulpitis? Is it cavity that is leading to pulp? Whatever it is, what is the periodontal condition? What is the hard tissue health? What is the soft tissue health? Everything has to be noted down, and a proper diagnosis is supposed to be formulated for a patient for you to be able to do the next step, which is the treatment plan. Now, treatment plan you do with a technique called direct mockup, which we have discussed as a small bit. Direct mockup is a technique that I use almost every day in my practice. I mean, not on all the patients, but the patients who I feel would benefit from veneers, or who are motivated enough to get a treatment done, because I choose my patients very carefully. I don't want to do a treatment and then end up with constant problems. Not that I don't have them, but I try to minimize them by choosing my patients. So remember, this is not a easy treatment. It looks like easy, it is sold like a easy treatment, but don't do any harm to the patient. If there are alternatives, if you see a 18-year-old patient coming for veneers, try to push that patient away towards ortho or Invisalign or whatever it is. So make sure that you make your treatment plan robust. Get a sign on the treatment plan by the patient for you and your patient to be on the same page. And finally, you should know about recent materials. I have got no doubt about that. But your basics are supposed to be strong. The bottle that you use for bonding agent, if you don't know what it contains, there is no point of using that bottle, because unless you know how that bottle is used to the maximum potential, how do you bond to a tooth, how do you bond to enamel, how do you bond to dentine, how do you prepare a tooth, everything is very important. So knowing your materials, knowing the dental materials that we study in first year again and again and again is very important. So the four things, just to repeat: pay attention to detail, have a proper diagnosis, have a proper treatment plan, and know your materials. Having a scanner with you is not going to make your dentistry better. It is only going to make it easier, but it is not going to make it better. Dentistry is about skills, and I would really want everybody to read the materials and know about the materials. Just to summarize today's lecture, again, we need to pay attention to all the details. I am doing this course next month. It's going to be on the 5th and the 12th. It's an online course purely. It's a 2-day extensive, 4 hours each. We're going to take through all the videos of each step of doing a veneer case properly. If you want to join in the course, you can get in touch with Dr. Juna, or you can directly message me on Instagram. I will be sharing the details for you. The course fee is going to be 9,999 INR. I have kept it at that. I have not increased the price, even though the early bird is closed. But for anybody who has attended this lecture, want to join the course, you can join it at 9250, which is a further discounted price. So in case you want to join this course, you are more than welcome. You are more than welcome to drop me a text. The QR code is right there again for you to reach my Instagram page. If you want to follow me, you want to have updates on dental materials, dental stuff, please do get in touch with me. I'll be more than happy to help you out with your doubts. I hope you really enjoyed this rapid fire 45 minutes of lecture, because I know online it is tough to hold the attention. If you have any questions, I'm more than happy to answer. If you have any questions regarding today's lecture or any problems that you face during your cases, you can. I have some time. I'll quickly take you through one or two of my cases, and then we can do the question answer session. So I showed you this photo before. We saw this quick snap of this patient. Oh, now at this time only they have to install the update. Okay, let the update be installed. Let me go to the chat and we can answer some questions. You can type in some more questions in there if you have. Let me take few that have already come in. So how, Dr. Imani, how do I start designing? I'll show you the case so you will also understand it once the update is done. But how I generally look at it from my perspective is, number one, first I see whether I'm changing the occlusion for the patient or I am not. Is it a confirmative case or a reorganizational case? If it is a reorganizational case wherein I'm changing the occlusion, patient has got severe attrition, erosion, the bite is not correct, and I know that if I do just veneers and they are going to fail, then the whole plan changes. For now, if we stick to cases which are generally simple, wherein you just have to improve the aesthetics, the bite is okay, I will do the direct mock-up. I will try to tell the patient that this is where we want to achieve the result. I'll take some measurements from those direct mock-ups that I have done, take an upper and lower impression, send it to the lab, send all the details that I want. They will do the 3D design, or they will do a wax up for me based on whatever they want to do. I will make indexes from the wax up. I will do the mock-up in the patient's mouth, show the patient the final result. Patient is happy. I prepare through the mock-up, do a cord packing, do an upper and lower two-step impression. I do a perfectly well adapted provisional on the patient's mouth, get my lithium disilicate veneers, and then bond them. So that's generally my protocol in terms of doing a case. But I mean, I hope I have answered your question. Dr. Rabia, I generally don't believe in prepless veneers. There is no evidence or scientific research that would substantiate a prepless veneer. Even though the patient has spaces, patient has small teeth, I would still prepare a little bit of a margin so that I can get a perfectly good adaptation of my veneer onto the tooth without leaving any ledge. So prepless veneers, I mean, I have never done it. And I mean, I have never seen an article that would do a systematic review on a prepless veneer and has come out with a conclusion that yes, prepless veneers can be done. So yeah, a lot of people promote it, but either the veneers will be very thin, or the veneers will be very bulky, or you will have food impaction or gingival inflammation, because if you leave a ledge anywhere, it is going to create a problem. That's basic biology. If I do a crown lengthening procedure, Dr. Poonam, I would generally ideally wait for 3 months, but in clinical practice, I cannot wait for 3 months. I will at least wait for a month before I do anything on the hard tissue. I use temporization in all my cases, whether it is a root canal treated tooth, whether I'm doing a crown, whether I'm doing an overlay, whether I'm doing a full mouth veneers. I don't let my patient go out without a provisional. So provisional is a mandatory requirement when it comes to a good prosthodontic practice. I have told Dr. Rabia prepless veneers is, I mean, I don't do it. Again, I'm not authority to tell you that don't do it, but I can definitely tell you if you do a prepless veneer, chances of failure are very high. Maybe the veneer might not fracture, but it might be an aesthetic failure, veneers too bulky, or soft tissue failure, wherein patient will have halitosis, gingival inflammation, bleeding, or so on and so forth. Dr. Tarun, I generally don't do direct composite veneers, but yes, the composite that I love the most is Tokiyama. I've been using Tokiyama for now few years now. I really like that composite. It helps me in getting good aesthetics with not much of steps. I'm not really into doing the enamel, what do you call, the mamelons and all, because as an adult, if you look at an adult tooth, you will hardly see those translucencies. It's more of an Instagram fad. If you try to do a lot of translucencies on the edge and all, it starts to stain very quickly. You spend 3 hours making a nice central incisor, and 2 weeks later, the patient has lost the polish. So I would generally prefer doing indirect ceramic veneer, and I generally don't do direct veneers in my practice. I would generally refer it to somebody else who does it. Dr. Kritika, for provisionals, I would keep it for depending upon my lab turnover time. So generally, my lab turnover time is around 1 week. So my provisional stays in the mouth for a week. So that's the thing. Um, Again, Dr. Tarun, there are a lot of techniques. Recently, we have a technique wherein you can make a clear index and you can do the flowable injectable veneer technique. But with composites, my main concern is that it loses polish very quickly. And when it loses polish, yes, patient feels better. It is cheaper compared to a ceramic veneer. It's probably a little less destructive onto the tooth. But in general, I feel if you do a good veneer prep, which is minimal, you are not really harming a lot. Okay, so it depends on clinician to clinician. My preference is indirect veneers because I have seen really good results with it. I have got good follow-ups. So that's generally how it works with me. Dr. Rabia, bruxism is something that is a big topic to discuss. Now, it depends for you to understand. A lot of times we think the patient has bruxism, but you see the teeth and you forget to look for erosion. Patient might have eroded the teeth and you think it is bruxism. So you need to look for clear-cut signs of bruxism, masseter's hypertrophy, constant pain in the head, constant pain in the muscles. Patients has a facial features of bruxism. If the patient has bruxism, most of those patients have lost vertical dimensions. Most of those cases will go for reorganizational approaches, wherein first I will correct the bite. Once my anterior bite is corrected, I'm able to provide a good guidance to my anteriors. Only then I would do veneers. If I know a patient is a bruxist, I would not just do veneers without evaluating the bite. For fluorosis, see again, anything that you are treating, if the enamel is not intact, it doesn't matter that you cannot do it. It's just that your patient should be educated enough to understand that you are not bonding to sound enamel, and there is a very high chance of debonding. So the poorer the enamel, the more chances of debonding. But I have done cases on fluorosis, I have done cases aminogenesis imperfecta, I have done molar incisor hypomineralization. If you do proper bonding techniques on the healthy tooth that comes out, it should kind of stay. Can patients chew on hard food with veneers? I mean, that's a question that is tough to answer. You can chew. If you look at a compressive strength of lithium disilicate, it's around 380 to 500 megapascals. That is very much similar to enamel. Yes, if you do proper bonding, you do a monoblock concept, ideally the patient can chew. But would you? After spending so much, I tell the patient that there is no food that you cannot cut and eat. So just eat from your back teeth. So the more care you take, it's like you buy an iPhone and you put a screen on it, you buy a case for it. Similarly, when you do veneers, you have to take care of them. If the patient is not motivated but has got a lot of money, that doesn't make him a good candidate for doing veneers. 42.2 rule, just to kind of, recap it for you. 4 is the incisal display at rest for females, around 2 to 3 for males. 2 is the amount of pink that you should see. So a little bit of papilla, a little bit of gingival tissue when the patient smiles maximum. And 2 is the distance between your incisal edge and the vermilion border of your lower lip when the patient is smiling. So that's the 42.2 rule. Dr. Bharat, I generally don't decide it much. For me, it's around 70%. My lab knows it. I tell them not to follow the golden proportion. Don't have my centrals too dominant, because in general, at the end, it would not require. I mean, it would not look very nice in most of the patients. So you need to have a little bit more harmony, and red is a better proportion when it comes to providing harmony to patients with veneers. Peg lateral requires veneers. It depends on how much you have enamel to bond to. If a peg is really a small peg, you can do a crown. You'll have more enamel to bond to. But if you have a decent enamel on buccal and proximal sides, I don't think veneer is a bad idea. I mean, I have done veneers on peg laterals and they stay. Prefabricated, I have no idea about these veneers, to be honest. As I told you, I'm not a fan of composite veneers. Their strength is not strong. I mean, they chip, they break way faster than a ceramic veneer. But again, if you feel your practice is more dominated by composite veneers, you will get more patients. You can do it. But as a clinician, I'll have to look into this because I have never heard of these veneers. I don't do these. So I'm sorry, I will not be able to answer that question for you, but I'll find and I will do it. Edinburgh degree route procedure after BDS. This we can discuss later. You can message me on Instagram and I can help you out with it for sure. Don't worry about it. After BDS, you will have to do the MFDS. And after MFDS, I think there is a time for a few years after which you can apply for a fellowship without assessment. That's as far as I know. I always prep with mock-up on. That's why I wanted to show that case to you. So the prep is always through the mock-up. I never touch the tooth directly. So it's always the mock-up done for veneers, and the preparation is always through the mock-up. Okay, so I mean, in general, that's the thing. Let me quickly see if I can find something for you just to kind of show you if I have it here. One second, all right. If I have that video with me. Yeah, I mean, I can just quickly show you. This is what we discussed during the course when we actually do it. But the preparation is always going to be through the mock-up. So you see that I always start with the mock-up on, and then we go step by step. We do the grooves and we kind of mark them. But the preparation, so till the time I am done with my grooves, my mock-up is on. The moment I am done with all my markings, my depth markings, I can remove the remaining provisional. So now the provisional is removed, and then the preparation is happening, and the preparation would kind of end something like this. So again, this is something that is like not possible for me to discuss now. But yes, preparation is always through the mock-up. Tetracycline stain, the only thing with tetracycline is that you have to prep a little more aggressive. You need to give the technician enough space for a ceramic to be fabricated that is slightly opaque. The cement that you choose is going to be a white opaque cement from 3M. It doesn't allow the tetracycline to show through. And you need to tell the patient that the prep has to be a little bit more aggressive compared to a tooth that is not a tetracycline stained tooth. But apart from that, not really. I have not incorporated the BOPT technique. I do a standard prep. There's a decent margin. I need a better adaptation. It doesn't matter if you have a 0.5 millimeter margin at the what do you call the gingival level. Most of my margins are supragingival or equigingival. I hardly go subgingival because if a tooth is root canal treated, it is discolored. I would first whiten it, make the stump better, and then keep a equigingival margin. So, I mean, margins, of course, will change in few cases. Again, that's a full case discussion on where I go subgingival, where I break the contact, and where I don't break the contact. Again, like just to kind of give you a small idea, if it's a case of diastema I'm treating, I put my margins subgingival. Now, there's a biological reason for doing that, but subgingival, I go only in cases if the tooth is really dark in color, or if there is a diastema that I am going to close. It can be a good option for a fractured crown at a middle third. If you have more than 30-40% enamel left, you will still be able, it's better than doing a crown for sure, better than doing a composite, because that composite is going to break pretty quickly. So a case that has got a fractured tooth, you have waited it out, you have checked the tooth is vital, because if you do a veneer and the tooth gets non-vital and dark, the veneer that you do is going to fail aesthetically. So you need to make sure that the tooth is vital, or you do a root canal and make sure the tooth doesn't change the color, clean the chamber properly, do some internal whitening, and do it. How to give provisional and average cost of veneer? Again, average cost of veneer is very subjective, Dr. Shalini. It can range from, I have clinics out there in Dubai that would do 20 veneers for 4,000 dirhams, and there are clinics in Dubai that would charge $4,000 per veneer. So, I mean, you have to decide your value, and you need to decide your lab cost and everything, and see that you're making profit out of it. How do I give provisional is again a topic slightly out of today's discussion, but generally I use ProTemp, no spot etch, no bond. It will directly be fabricated on the teeth. And because of the shrinkage properties of your provisional material, they would generally stay on to the teeth. Yes, for tetracycline stain, the preparation has to be more. It has to be at least 1 millimeter of thickness of ceramic that you have to provide, so that the ceramist can hide the discoloration from outside. So yes, tetracycline, the prep has to be slightly more aggressive. How much diastema? It depends. I mean, if it is more than 3 millimeters or 4 maximum, I would send for an ortho. Or if the patient says I don't want ortho, then I would do at least 4 veneers to kind of make sure that it kind of stays there. FDS is not similar to MDS. MDS is a 3-year course. FDS is just a degree that you get. We discussed about this, Dr. Kavita, about bruxism. You need to find out the reason for bruxism. You need to find out where the guidance is coming from. Is the patient group function? Is the patient canine guided? If you don't know where the guidance is coming from and you just do veneers, they will end in failures. So if you know your occlusion nicely, it would be easier for you to plan a case better. There is no contraindication of not doing veneers in clenching habit, but you need to make sure where the contact of the tooth is coming. Is it only clenching, or it is grinding bruxism? Is it daytime? Is it nighttime? There is so much to kind of again go into that. I'll take 5-6 more questions, guys. I think we are running out of time because then there will be more coming in. In class 3 malocclusion, I mean, it depends. I would not do it because I know if I increase the length even by a millimeter, there's a very high chance of fracture. So class 3, I've never had a case in a class 3 where, I mean, if it's a functional class 3, patient has got attrition, teeth have been eroded, patient has come to an edge to edge bite, then you record the centric and you can do it. But if it's a spherical class 3, I mean, tough to do veneers on those cases. How to manage zenith? By either cautery or by laser or by a blade, whatever you feel like you can do it. IDS, again, I personally don't do it. I've read a lot of recent literature that would say that it doesn't have any added advantage over doing a delayed dentine sealing while you are bonding. But if you want to do it, I mean, there is no harm in doing it. But literature has not made it a necessary step that has to be done, because if you have to do IDS, which is called immediate dentine sealing for people who don't know, is you need to prepare under rubber dam. It has to be absolutely isolated. It has to be only the fresh dentine that you do. If any of the 3 criteria are not met, your IDS is not happening correctly. The question of how much cement to be used, I mean, no, I mean, it depends. I mean, if you're using a proper resin cement, you can use whatever you want to. The moment you press, everything will come out. It should be enough so that it covers all the surfaces. But even if you have more, it will come out. It will not, because if you're using a pure light cure resin cement for bonding a veneer, it is thin enough for it to come out when you press it. What about using a universal bonding agent? I mean, universal bonding agent, also you should know which company universal bonding agent you have, because not all universal bonding agents have got silane in it. So if you're not sure if your bonding agent has got silane, use a silane on the ceramic. I have been using universal bond from 3M and I apply. I don't use the silane separately. I never had a debond as such. I've had chips and fractures of veneers, but no debonds. So I mean, it works. But if you want to be really kind of okay, just apply silane, buy a silane and apply on the lithium disilicate. I give generally supra or equigingival margin. I would hardly ever go subgingival. Dr. Shalini, thank you. I mean, people are typing and done. Okay, no more questions after these three questions, guys. Composite doesn't stay because of edge-to-edge bite. Veneer would stay more than the composite, but if it is an edge-to-edge bite, I mean, it's tough because at the end of the day, you are bonding something onto the tooth. At the edge, the ceramic is thin. So I would suggest to do two veneers on both the centrals and correct the edge-to-edge bite, or send the patient to orthodontist, or if you do Invisalign, correct the bite a little bit before you do your ceramic veneers. Gummy smile, I don't really mind gummy smile for most of my patients. Most of the patients also don't mind the gummy smile. I would do it the regular way, but I will have to make sure that the soft tissue aesthetics is maintained as well as the health, of course, is good. If at all patient says I don't like it, I am doing some Botox in these areas. I inject some Botox here and it would kind of work very well. Emax is better because you can bond it. Zirconia you can bond, but still not as good as lithium disilicate. And plus aesthetically wise, lithium disilicate is more glassy and it looks more natural than zirconia. I mean zirconia, even though the 5Y zirconia is aesthetic, but I would prefer a lithium disilicate. And most of my practice these days, even for posteriors, is lithium disilicate. Zirconia I have kind of slowly reduced in my practice. How do I remove temporaries? If you have not spot touched, you have not done any bonding on the temporaries, which I don't do, you would be able to remove them easily. You can make some grooves and then just take an instrument and break it off. So that's what I kind of do. So thank you for all. I mean, just before I let me see if my thing is updated. I can quickly. It's still updating. Let me see if I can open the case for you in the PowerPoint. I have the keynote. Yeah, I mean, I can show you the case here. So this was a case, I mean, I wanted to show you for you to understand the aspects of smile designing. A case like this with a midline diastema, triangular teeth are eroded. I could have done two veneers for this patient, but two veneers would have ended in a slightly broader central incisors. So what I decided to do was four for this patient. These are the pre-op photos. That's the mock-up that I do. Everything analog. The preparation is always through the mock-up. So these are the steps of my preparation. These are my final prepped veneers. So people who are asking me about subgingival, because I was closing the diastema here, in the midline area, my margin has gone slightly subgingival. So those are my final veneers. Told the lab to have slightly broader contacts, super healthy soft tissue on the day of bonding. That's the final result that I achieved. Okay, soft tissue remains healthy, better proportions of the teeth. There is no gingival inflammation after a month, 2 months of bonding, and everything looks super awesome. So, I mean, that's the prep protocol, and that's the final. I hope you had good time. I mean, I really enjoyed talking. I always like this topic. It's a topic that I love to talk on. Again, if you have any questions, please feel free to drop me a text on Instagram. I'll for sure reply to it. And I hope you guys had fun. Dr. Juna, I think we are done.
Yeah, Doctor, thank you so much. Thank you so much for
Yeah.
sharing your knowledge and expertise when it comes towards managing psychology of smile designing. Surely, many of us would leave this discussion with amazing takeaway points and implement techniques as per discussed. Thanks to all doctors for patient listening and your participation for this webinar, and I hope all of you will depart this session with positive, confident manner. Once again, thank you so much, Doctor. It was a wonderful and informative session, and we really appreciate your valuable time given to us for this series episode. Please do check out and follow Doctor's Instagram page where you can appreciate his clinical works. And to know more about our upcoming webinars and workshops, please do check out our website, which is iadp.org, or you can follow our Instagram and Facebook pages as well. And if you have missed our previous webinars, do check out YouTube channel as well. And we really appreciate if could subscribe as well. So thank you all and have a great night.
Thank you.
Thank you, Doctor.